Hello and welcome back to our series Making the Cut on cutover planning. Today we are going to be talking about clinical cutover, and we have a special treat in that one of our clients, Gail Boushley, is here. She is the team leader for training and optimization from Bellin Health, and she is joined by Megan Rice, who is a practice director at Nordic. I'm John Pollard, part of the marketing team here at Nordic, and I think we're going to have a great conversation. Gail, why don't you tell us a little bit about yourself?
At the time when we went live with Epic, I was a manager of an inpatient unit and also the operational lead for the Epic implementation. I've been a nurse now for 30 years, so I have a long-standing clinical background.
Sounds like we picked the right person to be part of this series. Megan, how about you?
Yeah, so I'm Megan Rice, and
You're not a nurse.
I'm not a nurse. I would not even get close to thinking I was one. But I have an Epic background. I was a consultant with Bellin and worked on Gail's team as a ClinDoc application lead for the team here, and I am currently the practice director over Nordic's inpatient consultants.
Excellent. So Gail, when we're deciding what kind of data to enter, what sorts of data are we looking at? Why? What type of guidelines do we want to put around that? Go.
So when we looked at what was in a patient's record, some of the more important things that we wanted to capture on every patient was allergies and height, weight. Those are critical in making decisions, especially in our ICU department with titrating meds. So we wanted to make sure that we had that consistently across so we weren't creating any situation where we could harm a patient. Then we also met with our clinical nurse specialists, nurses from each of the departments to identify what they felt was critical information for them to come into a record and need to have quickly. So we looked at ICU and we said if they're on frequent vital sign monitoring, then we would want to do the last 2 to 3 hours worth of data. Depending on the situation, if it was an open heart patient, we're going to need more data to start out with. In our regular units, med-surg unit, cardiac general unit, we looked at the last assessment that was done. We would put that into the system. So the last set of vitals, we did a total I&O, so we weren't putting in incremental, looking at that information. We put in past medical history because that is something that a physician would need to look at quickly.
Sure.
Substance abuse was another one. If we had someone that was potentially could go into detox, we needed to know about that. Past patient medications that they take at home, we did need to get that in there. So those were the critical components of that record, the legacy system that we needed to get in there. We did not bring in any labs. Those we still kept on a printed sheet for that time period, and then put in the orders for those for future. But it was pretty much just that last assessment that we wanted to capture. Babies in the newborn nursery, we wanted to capture their last feeding. That was critical. And then for our mothers who were in labor, we wanted to be sure to capture their prenatal history in there to make sure that the doctors had that, because at any time that baby could come, so we needed to make sure we had that in there.
I think they say expect the unexpected at Go Live,
Yeah.
so we tried to prepare for as much
And
as
we didn't want to put too much in there either. That would be overwhelming when you first went into the chart as well.
Right.
And lines, drains, airways was another big one.
Yeah.
Why not the labs?
Our labs were in one format and we were switching to a different format. So any of the previous labs we just left as is on that printed form. And then at conversion, when we went live, they would be in the Epic system. So it was just easier to keep it clean than to try to import data that's already been archived.
Yeah, they were interfacing the lab results because they weren't up on Beaker yet,
Right.
but they interfaced the lab results from their previous LIS, but they weren't manually entered at the conversion time.
Gotcha. Okay.
But the orders for any future labs that were going to happen, those went through. So there was a whole section of non-medication related orders that the group of super users who were doing the conversion entered, and then the pharmacy team of pharmacists entered the medication orders to make sure that all of the medication information was accurate and there were no discrepancies, obviously, to prevent any safety issues.
Yes. And having the pharmacist enter those orders saved us an extra step of them having to verify. So if the nurse entered the order, then the pharmacist would have to verify. Having them put it in directly, we eliminated a complete step.
Sure.
Saved us some time.
Yep.
Yeah. Were there specific guidelines that you had in place for this then?
So we had outlined this well in advance and had this reviewed by our risk management and our quality department and our CNO along with our CMO, making sure that we were meeting all the requirements of data that would be needed in an emergent situation. And they felt we were right on track with that. And the nurses really do know the record the best, and they were able to really outline what it is they needed to be able to. If they called a doctor at 3:01 after they flipped the switch, they'd know where to go.
Yeah, and there were guidelines when we did a dress rehearsal, which I think we're going to maybe talk about a little bit later. There were guidelines that were printed for each of the different pieces of information so that the conversion team knew. We talked about it again in the training so that they kind of knew in their head what guidelines to follow, but there were actually printed sheets of this is the information around height, weight, and allergies, which was pretty self-explanatory, but things around some of the ordering pieces, like do I enter these orders or not these orders, that was outlined ahead of time.
Now, when it comes to determining which departments should come first, which patients come first, how do you go about that thought process?
So we looked at departments that had the most critical and the most rapid turnover of patients. So one of the departments is our ICU. That department has the highest acuity patients. They will have patients come in rapidly, and so we needed to be sure that we've put a lot of energy towards them first, so that if they had any patients that would need to go for emergency surgery, we were pretty well set with those patients. We then focused on our OB department, which is another high, fast-paced unit that we needed to be sure that we had that all captured, and then worked our way down based on the volume of patients. So our medical unit, which is a highly utilized unit, always full, we went there next. And our last unit that we went to was our inpatient rehab department. Those patients don't usually go anywhere, especially in the middle of the night. So they were we hope. They're very stable, usually very inactive on the night shift, so we left them for last. So it was looking at acuity, volume of patients in an area that you anticipate, and movement of patients. So that's how we figured that out.
How did you handle new admissions then?
We had our downtime paperwork created, and one of them was an admission based on the Epic build. So if we had a patient that was admitted during that time, we used that paper form, and then when we were up live on Epic, then we put that information into the system for that patient. So then they were right off the bat in the new system.
Excellent. Now, can you talk to me about like the conversion on the unit versus the command center and how you had that all set up?
So we had our command center where we had all of our analysts housed, and that was for 3 or 4 weeks actually we lived there. But we had a place to start. We all grouped in the one room, went over our plan one more time with all of our staff that were going to be helping with the conversion, making sure we had everyone there, everyone was in sync on what their role was, and then we just dispersed them out and actually cycled them the first time out. We sent our height, weight, allergy people out, and then we gave them a little bit of a head start, then sent the next group out, and then they just moved right down. We had this big whiteboard that we had identified department, who was going to be where at approximately what time, and it just worked it through. And if they ran into a problem, they would let us know. We'd get them the help they needed. And we would let the next department know that the next group is coming. So they always knew when to expect the next group of people, so they had their on-the-unit helper ready.
And how did you determine that schedule? That unit by unit or team on each unit?
We discovered the timing by doing our dry run. And we actually,
Interesting.
we took an actual patient chart and converted it into Epic, so we would see how long it would take. We had actually a couple different patient charts to get a different feel for someone that was in the critical care department. We had someone on a regular floor and used an actual chart, and everybody tried each section, and we timed it to see how long it would take us to do. So it was a lot of, okay, I'm starting allergies, done, raised our hand, and
Gotcha.
we calculated it out, and we did a pretty good job.
Yeah, we did a couple of dress rehearsals in the test environment before the night of, which was really good on a number of different levels, because obviously the decision makers who were helping to determine the plan had a better sense of, okay, I'm not so scared about what this event is going to look like. We've kind of been through it before, but it also gave the people who are going to be doing the conversion a chance to practice and really get their hands in the system. And we came up with a lot of really good questions out of that of, do we really want to look at this anymore, or should we, maybe try it this way instead? So it was really successful.
I agree. We actually finished a little ahead of time.
Wow.
And we had a pretty full house, so
Yeah.
it went very well.
So another shout out for the dry run, apparently. Yeah.
Absolutely.
Practice, practice, practice.